Thank you guys again for being here. My name is Alexa Tinsley. I am the Director of Programs here at Jett Foundation. We appreciate you all being here today for our webinar series on management and access to care for female carriers of Duchenne. We cannot wait for you to hear from Dr. Larry Markham. Thank you for being here and sharing your expertise and knowledge with us in the community. Dr. Markham currently works with patients at Riley Children's as the division chief for pediatric cardiology, and he's also the co-director of the Heart Center there. His clinical interests and investigations have been focused in congenital heart conditions and inherited conditions, with one area of focus being Duchenne. He's worked on multiple working groups for Duchenne, including for the CDC with PPMD, and he's also currently involved in Duchenne research. So he is very knowledgeable about the subject. So we're very excited to have him here. So thank you again for being here and giving us your time. Before we get started, I do just want to mention a few things. We do hold these webinars throughout the year. So please go ahead and check out what we have on the docket if you haven't already. This webinar is being recorded, so if you have to log off for any reason or lose power or whatever that happens to be, if you do know anybody who was not able to make the webinar today but did want to, it will be recorded and on our website and YouTube and Facebook videos later for anybody to watch. So after this presentation, we will be doing a Q&A. There's a question box in your bottom panel. For me, it's on the right-hand side. It has two little boxes. So we do prefer you to put your questions into that. We do our best to monitor the chat and find questions that come through there. But our primary way of answering those questions will be that Q&A panel box at the bottom. We do try to get to Facebook questions as well, so we do monitor that. We do our best to put those in as well, but if for any reason your question does not get answered, please reach out to me at alexa@jettfoundation.org and we will make sure it gets to Dr. Markham. So with that, that is all from me, and I will hand it off to Dr. Markham. Thank you.
So thank you, Alexa. It's a great opportunity to speak with you, and I think the introduction of webinars after COVID has been a welcome addition to connect with people who you may not have had the opportunity. And so this certainly expands our educational offerings. So I'm excited to give this presentation on the management and access to care for female carriers. I see kids, but I also see grown-ups. So it is an area that continue to need more attention. So with that, I have a few disclosures, mostly research funding. And so I am heavily involved in Duchenne research. And so as a way of introduction, I think it's very important for us to cover some of what we know about Duchenne boy cardiomyopathy, because I think that helps or should help inform us about carrier cardiomyopathy. And so we'll start with a 30,000-foot view. This is Indianapolis from an airplane. We'll then dig a little bit deeper and get down to where we might see some of the buildings. And then we'll touch on some very specific things. And this is our city center from ground level. So my outline will consist of a couple of areas. So one is why see a cardiologist as a carrier? What is the risk? And so, as I mentioned, we'll talk about the impact of dystrophin on the heart, a little bit about the natural history, but then we'll also get some things specific to carriers, such as defining cardiomyopathy, heart failure, when to evaluate the heart, and then some bullets on treatment. So with respect to dystrophin, this is a nice cartoon of dystrophin and where it sits within the muscle cell. And so dystrophin is a structural protein that provides mechanical support of the cell. So it's sort of the shock absorber of the cell. So when we contract our muscles, we actually damage the muscle a little bit. Skeletal muscle is very good at regeneration and repair, whereas cardiac muscle, not as good. But dystrophin and this whole dystrophin associated complex also does a lot with cell signaling and how cells talk to each other. So, how does it handle the pressure response of when we stress the cell? Nitric oxide synthase helps blood vessels relax and helps more blood flow get to an area, and then cell survival and death. And if you look at the cartoon on the left hand side, you see all of the different conditions which are associated with the different proteins in this complex. And so when dystrophin is absent, a lot of these proteins are also disrupted. And so that just is a clue of the importance to muscle function. And so we have when there's dystrophin loss, we know that the molecular structure of the cell is abnormal. But when you look at the heart muscle very early on in life, and for some patients, the heart muscle function is normal. But we know here in the middle, when you have muscle cell injury, death, inflammation, altered energy metabolism, that all leads to chamber enlargement, abnormal wall stress, and contractile abnormalities. And then you get to the point of having a dilated cardiomyopathy with altered molecular structure, but also altered muscle function. And in Duchenne, this is an increasing proposition with age. And we'll go through some of the age-related associations. And so if you look at Duchenne boy cardiomyopathy, this is the percentage of patients who have an abnormal ejection fraction by 5-year intervals, such that it is unusual for a boy less than 5 years of age or even less than 10 years of age to have heart muscle weakness. Having seen hundreds and hundreds of boys with Duchenne, I can count on a couple of hands how many boys less than 10 have been severely impacted. It does happen, but it's not that often. Whereas boys greater than 20 years of age have a higher chance of having an abnormal ejection fraction. As we'll talk later on, that does not mean heart failure. That does not necessarily mean that your life is shortened. It just means that your heart muscle function is not normal. This is a slide of, I would say, the 10 largest studies in Duchenne that represents probably over 1,000 patients. And this reports the average age of abnormal ejection fraction or shortening fraction. And you see that on average, 15 to 16 years is when most boys will have abnormal ejection fraction. And so if you go further back and look at autopsy studies from the 70s, pathology studies, even some heart cath studies, which were performed in the 80s, where heart muscle tissue was evaluated. You see here in the top left, you see this white area, which is actually fibrosis or scar tissue. And the other figures here are pieces of muscle under a microscope. And you can see this white patchy stuff in between all the muscle cells. And so we had thought long ago that fibrosis or scar tissue within the heart was a big component of progression of muscle in Duchenne, but we really did not have a way to evaluate or assess that. And so Using cardiac MRI, I'll show you some other pictures, but you can see this white patchy area of fibrosis or scar tissue. And so we have come to realize that that is a big component of how patients progress. And so this is an example from a paper in collaboration with the team at Vanderbilt, just showing, and I did not put all the pictures here, but you see this panel on the left, you see the heart muscle, which is outlined here in black, and there is no white patchy area or scar tissue, which is present. However, when you look over here on the right, this is someone with a severity score of 4 out of 4, meaning they have fibrosis or scar tissue evident in the septum or the wall between the two pumping chambers. They also have scar all the way down the outside border of the left ventricle with the arrows here. So that's a very severe fibrosis or delayed enhancement. And so if we look at some of the larger studies, which began in 2007 with Silva and then Pachowski in 2009, which were the first small series looking at fibrosis or delayed enhancement in Duchenne. And that was followed up by 2 studies with Conhor and Tandon, which looked at a lot of patients, hundreds of patients who had delayed enhancement. And what they found was that 17% of boys less than 10 years of age already have evidence of delayed enhancement or fibrosis. And that increases with age, such that about 60% of boys over the age of 15. And interestingly enough, that ejection fraction seemed to follow the late gadolinium enhancement. So 30% of those with delayed enhancement actually had a normal ejection fraction at that time. However, if you looked at the patients with an abnormal ejection fraction less than 55%, over 80% of those had fibrosis or scar. And those patients with septal involvement were significantly older and also had a lower ejection fraction. And really what we have seen is degree of fibrosis and ejection fraction have implications for survival. And of that group, 10% of patients had died during the time of that study, and only 1 patient had a negative fibrosis or scar. And so we know that heart muscle is abnormal before ejection fraction falls. And Dr. Hoare had a very early paper in Duchenne, and it's interesting, this paper is 15 years old now, but it was one of the early papers to say we can stratify patients into different groups based on how they have progressed. And so some of these measures of circumferential strain describes how the heart squeezes. And so you can look in this first group that's better, they have a normal ejection fraction, they have a strain that is in a normal range, and they have no evidence of fibrosis. So for all of our measures, you would say those patients are normal. Whereas you can look at the Duchenne patients who have abnormal strain but do not have fibrosis yet. You have abnormal strain and fibrosis with an abnormal ejection fraction. So we can put people in a risk category. And then if you look, John Soslow and Starnes, the team at Vanderbilt, really looked at patients with strain over time, and you can see that the individuals who maintain a normal strain in this blue line are those that are doing well and alive, whereas those individuals whose strain starts to increase are those most at risk of progressive cardiomyopathy. And so we now have at least a better sense of that original diagram, which I showed the progression of disease with age. We actually can now have more detailed measures of how we can define the cardiomyopathy progression in Duchenne. And so the very important thing, though, is that our therapies need to target the pathophysiology of the stage of muscle disease. So very early on, some patients may have edema or inflammation of the heart muscle, and we can actually categorize them. Other patients have already progressed to fibrosis, which is scar tissue. And then there are other patients who have already progressed through this stage to a fibrofatty replacement of heart muscle. And those are the patients with the more significant disease and likely progression of their cardiomyopathy. So we are now getting to the point where, with advanced imaging, we can really refine what we think the heart muscle condition is in a Duchenne boy. So as it relates to carriers, we, in my opinion, should follow a very similar approach of investigating the heart muscle condition in a way that helps inform us of how a patient is progressing. And so I will say that the cardiomyopathy in carriers exist. There's a lot of data out there, which I'll go through with you. It's not as frequent as sometimes I think gets batted around, but there is some increase in worry with age, so we need to pay attention. This was a study out of Brazil looking at genetic counseling for Duchenne women carriers. And they looked and said, well, genetic counseling was performed for 63% of the women. So that's okay, but that means 1/3 of women with a child with Duchenne had not had genetic counseling. 54% of women reported that they had genetic analysis. Again, not enough. And the majority, though, knew about the risk of developing heart disease, but only 35% of women had cardiac studies performed at least once in their life. So entirely unacceptable, in my opinion. And so what does the data show? What studies exist? And so I'll try to walk through these because these are a significant number of patients. So, and they're from different areas of the world, some from Europe, some from the United States. And so, as I mentioned, the studies, they look, generally the studies that are reported are sort of cross-sectional studies where we evaluated all of the carriers that we knew about, and we're going to report the results. A couple of the studies followed women over time, but all of the studies actually had women of a long age spectrum. So this first study had 129 carriers, age 18 to 60 years of age, and they found that a formal diagnosis of dilated cardiomyopathy with abnormal function was present in 8% of women, and LV dilation or enlargement of the heart was present in 18% of women. And then if you look at the next study, 130 women, average age of 39, again, dilated cardiomyopathy was present in 13%, but only 3% had what I would say was a significantly decreased ejection fraction with symptoms, less than 40%. And then this next study evaluated almost 100 women with a median follow-up of 9 years. So they not only saw them originally, but they reported a second paper that was 9 years later. And out of that, 11 women developed dilated cardiomyopathy over that time frame. And one woman died of cardiac failure at age 57 years. So that would be infrequent, but enough to note. And then the final paper had a nice breakdown by age, where in total, almost 200 women had 6% dilated cardiomyopathy, where you can see the increase with age: 6% at 16 to 30 years of age, 9% at 31 to 50, and 16% of those greater than 50. And then more recently, and is just a great study, and I know some of you may have participated in this study. Dr. Ma and team at Nationwide evaluated 77 genetically confirmed carriers, average age of 41. But the thing I like about this study is they took non-carrier mothers and put them through the same testing. They also took controls, women who did not have Duchenne in their family, and evaluated them. And so they, again, found similar numbers of abnormal ejection fraction. So 14% of carriers had an abnormal ejection fraction. The striking thing to me was 49%, almost half of carriers had late gadolinium enhancement or positive fibrosis, but only one of the non-carriers and none of the control subjects. And the biggest finding was that 25% of the carriers had recovery ventricular ectopy. So what is that? So they not only did confirmed genetic testing, they did stress test, exercise treadmill stress, and then they did the MRI. And so patients, while they may not have had symptoms, had evidence of heart muscle irritability after their exercise test. And so they recommended, rightly so, and again, this goes back to the survey of carriers from Brazil, that genetic testing of all potential carriers is important, because your risk of whether you are a genetically confirmed carrier or a non-carrier mother should inform the recommendation for heart muscle testing for you. And so they recommended a cardiac MRI at some point in the third decade as part of the cardiac evaluation of carriers. And so I have just a little bit about X inactivation. So in the top corner is a woman who represented a Duchenne variant, represented by white. And so half of her is carrying the DMD gene, and with a deletion or duplication. And so she has a daughter who could be unaffected, because she would get the X from dad and the non-Duchenne X from mom, or be a carrier where the Duchenne X from mom and the non-Duchenne. Well, when a cell is being formed, if you have two X's, you only need one for that genetic information. And so the process of X chromosomes turning off can be random or skewed. And so if you, one way, and the reason that is mammals aim to maximize of one X chromosome in order to balance the X chromosome dosage between males and females. And so testing, however, can vary among muscle groups. And so while it's not necessarily recommended that every woman should undergo X inactivation testing to see which X is turned on for a particular cell. It is important from a research basis to think about because, and I'll give you a couple of examples. If you have a cell like skeletal muscle, for example, where the maternal X in pink here that's carrying the Duchenne variant is turned off and the paternal X is expressed, some people hypothesize that maybe that person would not have skeletal muscle disease. But one hypothesis is that if you have the paternal X turned off and the maternal X expressed that's skewed, and let's say that was expressed in the heart, maybe you have more heart disease than you would skeletal muscle disease. And there have been a couple of groups who've tried to look at that, and the results are a little bit all over the place. So if you look at muscle biopsy from skeletal muscle from symptomatic versus asymptomatic, defined by an individual's degree of weakness, you can see that in this one study, they found skewed X inactivation. So a higher degree of the maternal X in skeletal muscle only in 1/3 of the symptomatic patients and half of the asymptomatic patients. So their conclusion was there was really no association between X inactivation and the disease state. Another study tried to compare cardiac progression in carriers. And again, they had some conflicting results to a certain amount. They did not take cardiac muscle and actually look at the tissue, but they tried to determine that from lymphocytes or blood cells. And they suggested that non-manifesting or healthy females had actually more random, which is what you would expect. But then even that, mothers and daughters, whether they were symptomatic or not, didn't really follow the same pattern. So, and here's an example where you look at if your inactivation of the X chromosome is random, then 50% of X should be from mom and 50% should be from dad. And here's an example where it's skewed in some of the manifesting carriers. One is actually skewed the other way towards more of dad, whereas the other ones are skewed more towards maternal. So a lot of conflicting data, which is why it's not a clinically ordered test, but this is one area of future investigation to try to sort out how can we predict which carrier is actually going to have disease. And so if you go to the doctor and you're talking to a cardiologist and they say cardiomyopathy, what does that mean? Well, it actually means just any disease of the heart muscle. So in Duchenne, Becker, carriers, we're typically talking about a dilated cardiomyopathy. So in the top right is a normal heart, which has some thickness. And this heart in the middle is dilated, which is the chamber is larger than it should be. And the heart muscle has some thinning out because as it dilates, the muscle distributes more evenly. And so this results from muscle injury, cell death, formation of scar, chamber enlargement, walls become thin, function declines, and then a patient may develop symptoms. My doctor used the term heart failure. What does that mean? It simply means that the heart cannot meet the demand. And so heart failure does not mean that the heart is stopped. Heart failure can occur when the heart function is poor, but it can also occur when the heart function is good, but the demand is high. And there are a lot of secondary effects, which we'll talk a little bit about because that's how medications come into play. I will say that people can live with heart failure. And so that's an important distinction to make. So this is an example of stages of heart failure where someone who is stage A, for example, may have normal heart function, no symptoms, and then, but we know based on their diagnosis that they have a lifetime risk of heart failure because they are a carrier of Duchenne. Stage B is someone who may have fibrosis or evidence of structural heart disease, but they have normal function, no symptoms. Stage C is somebody who has abnormal function, no symptoms, and stage D would be someone abnormal function and has symptoms. So we can think about and place an individual in risk and then base our therapeutic and evaluation approach based on where they are. So, should carriers undergo cardiac evaluation? And so, certainly, if skeletal muscle symptoms can be present, oftentimes, though, cardiac may be the only manifestation. And given that cardiomyopathy increases with age, still not that frequent, but you're more important to be proactive than you are reactive. And so most of us would suggest a baseline evaluation as a young adult. The frequency is really unclear. Should it be every 5 years? Should it be less? Certainly, if you have any abnormal findings, it should be more frequent, and be aware of symptoms, which we'll talk a little bit. This is a hard one. Take care of yourself. Pay attention to your other risk factors: smoking, high blood pressure, cholesterol, family history of heart muscle disease. But the simple answer is yes, all carriers should undergo a cardiac evaluation. Who should care for your heart? A cardiologist is someone who cares for heart problems. You have pediatric cardiologists who their training was pediatrics and then cardiology. You have adult cardiologists who did internal medicine and then cardiology. And then cardiologists in and of themselves have subspecialty interests. So some are in heart failure transplantation. Some have experience in treating neuromuscular disorders. The big thing is there may not be someone local or close to you who has experience in Duchenne. There's probably someone in heart failure or transplantation. They may look at you and say, "You're too well. I don't know why you're here." But really, what you want to find is someone who cares and listens and is willing to have a conversation about the information you bring them with regards to what your risk is and what is the rest of the muscular dystrophy community talking about. So how will the heart be evaluated? The best ways will be looking at heart muscle function. So one is echocardiogram, which is here on the top, shows anatomy, function. We have a lot of fancy measurements with regards to contraction, relaxation, strain. It's readily available. It's quick. Sometimes the quality is not always optimal. There can be variable imaging quality, and it's not as good for evaluating the right ventricle. MRI, I sort of liken it to a dirty versus a clean window when you're compared to echo. You certainly can see the heart muscle here in detail, gives a little bit more information. The novel MRI would be evidence of fibrosis, strain, very detailed evaluation of the right ventricle. Although it's not available for everybody, it takes more time, and in some centers, it can be quite a bit more expensive. So what should you watch for? All the usual things: chest pain, fast heartbeats, palpitation, certainly syncope, collapse. Everybody should learn to take their pulse. Effort intolerance, difficulty breathing, and then you list some other things there. But If you look at most people, you've probably had any or all of those at any time in the last 5 years, and it may or may not be your heart, but those are some of the common things that people may experience. And so, what about treatment? Can the heart disease be altered? There's different approaches, which we'll kind of talk through. Treatment of heart failure, treatment of cardiomyopathy before heart failure is evident, and then treatment before cardiomyopathy is evident. And so it's sort of like prevention versus rescue. So you took swimming lessons, so hopefully you didn't drown. You turn the oven off or attend to your plugs or do fire safety so your house doesn't burn down. So if we are doing a preventive therapy, we would like that medication to have low toxicity, low risk, be able to use it for a long period of time, and we would like to expect benefit. So you don't want to do something beforehand if you're not going to get benefit. It should be a low cost, although if it works really well, one could say, well, maybe we're willing to spend more. And you have to treat a large number of patients to prevent one person from getting disease. However, if we look at rescue therapy, well, this person did not take their swimming lessons and now they're getting rescued from the lake, or they were not attentive to their fire risk. And so, but if we are rescuing someone, we will certainly accept more toxicity. We'll certainly accept more side effects, and we would like our length of treatment to continue to generate a response. We certainly want to benefit. Cost, if it truly works, maybe we don't care about the cost. And then you should be able to treat a smaller number with disease to prove that that treatment works. And so this is the goal of treatment in Duchenne and Duchenne carriers is, can we stop or mitigate some of these pathway abnormalities that impact heart muscle and lead to heart muscle weakness? And so this is a table from the Action Registry, which we work with and is doing a lot in the Duchenne space. But this is sort of a rough guide. So the approach of guideline-directed medical therapy based on your risk profile as well as your disease state. And so I would consider this approach applicable to an individual carrier who has heart muscle disease, which is ACE inhibition or angiotensin receptor blocker, then mineralocorticoid receptor antagonists such as eplerenone or spironolactone, beta blockers, and the newer therapies, which we're starting to use more of. And these give you some rough guides. So a couple of words as we finish up here. Optimism is defined as the tendency to look on the more favorable side of conditions and expect the most favorable outcome, or a belief that good ultimately predominates over evil. And some synonyms are confidence, hopefulness, cheerfulness. And so there is some optimism in Duchenne. So when I started in Duchenne 24 years ago, 23 years ago, there were no care guidelines for Duchenne, no care guidelines for carriers. Well, now the majority of care consensus guidelines actually mention carriers and talk about carriers. So there's an increased awareness and enthusiasm for getting the information out. If you look at care, for example, care is vastly different than it used to be. And so there is access to knowledgeable individuals in the Duchenne space. And then optimism. If you look at NIH funding specific for Duchenne, and this paper is already 14 years old, but you can see over the last 20 years the increase in research funding for Duchenne. We recently were awarded a multi-center grant to further evaluate Duchenne cardiomyopathy, and these are all the centers who are participating. And so one of the things we have been doing over the last 10 years is really trying to define the natural history and determine the metrics which make a patient go from low risk to high risk. And so all of these centers are participating. There's other centers who are planning to join. And so this time next year, I'll have to update this with a new slide. So the other optimism is publication. So if you look at the number of publications in Duchenne cardiomyopathy, it's drastically increasing over the last decade. The same thing in Duchenne in general. These two events here are the discovery of dystrophin, and the other one is the MD CARE Act, which certainly designated additional funding for Duchenne. The therapeutic pipeline, when I started in Duchenne, you could not create a slide such as this, and now this slide is probably 5 years old, so doesn't even include everything. I will talk about carrier research in that there is research such as at Nationwide that is going on. And I talked about therapies, and there are more and more women who have access to proactive treatment strategies. And there is discussion, at least in the pharmaceutical companies that I have talked to or engaged with, that the carrier population is one that is on their radar of needing therapeutic trials going forward. This is probably the ultimate optimism in my mind, is that if you were a boy with Duchenne born in the before 1970s, your survival was significantly less than if you were born in the 90s, where the average life expectancy is now extending into the fourth and even fifth decade. And so in conclusion, as we wrap up here, there is growing optimism in Duchenne, including carriers. Survival has increased and the natural history of cardiomyopathy has changed. There are newer imaging modalities which detect things earlier. And so there are a lot of people working on defining a set of abnormalities which put patients in a high risk or low risk category, and therapies are now available. There'll be future cardiac specific therapies. And so how can we optimize those to further improve cardiomyopathy mortality? And heart failure treatment after cardiomyopathy is beneficial. Earlier treatment prior to cardiomyopathy is unproven, but likely beneficial. And it is important to consider the risk benefit for each individual person. And we need to use common sense and have an open dialogue with all care providers. You are the most important member of the care team. And I will say that I think your boys warrant you to think of yourself on occasion and to be a little bit selfish and make sure that you're okay, so that you're around to take care of them because they're going to be older. And so these are some of the people through the CARE Consortium who we've worked with and published with. This is the funding organizations that I have worked with. And so that was all I had. Thank you very much.
Thank you very much. We have a lot of questions, so I'm going to try to get to them in the amount of time that we have. So
Sure.
I'm gonna start with I'm actually going to combine two questions. So, at what age would you recommend girls getting their first MRI and other cardiac tests? But with that, I think one of the biggest barriers is getting the right diagnostic testing. And how do you convince a cardiologist to know that an echo is not enough for females, pediatrics, and adult?
Yeah, so I usually start with what is going on with the patient in and of themselves. So if you had a 15-year-old girl entirely asymptomatic who's not weak in any way, shape, or form, I think at that point in time, an echocardiogram is sufficient. And if that is entirely normal, we have evidence from all these other studies that the likelihood that an MRI would be abnormal is exceedingly low. However, if you have a symptomatic person as a teenager who has skeletal muscle weakness, maybe the echo is not entirely normal, or a couple of the studies looking at carriers suggested those with significantly elevated CPKs were more likely to have an abnormal MRI. And so if you are a symptomatic individual with a significantly elevated CPK, I still would start with an echocardiogram because that's going to allow the cardiologist to jump up and down and petition your insurance company to say, listen, we have an echo that's normal, but there's data that exists that maybe that's not enough. So my next evaluation will be an MRI. And so that's how I would start with a teenager. Certainly, if disease is more or the patient is more symptomatic, then that's a different story. If a woman, and what the Dr. Ma's paper suggests is the third decade in someone who is entirely asymptomatic and has no concerns for just a screening, I want to do this kind of test, which I would agree with that.
So, you said CPK levels being elevated. So if someone doesn't have a genetic test yet,
That's step one.
Thank
That's
you.
step one.
Yeah.
Yeah.
Awesome.
Because you got to know if you're a carrier or not.
So with that, at what age do you suggest someone be tested if the mom is a carrier, not from an ethics standpoint, but are there health reasons?
That comes down, and we had this in clinic the other day where we were talking about it. That comes down to the individual family decision, I think. Not an ethics standpoint, but just, do we want to introduce more stuff for this 10-year-old girl who's already got enough on her plate, and now she's got to go do all these tests because we did this other test? And so I tend to lean towards, in an asymptomatic person, at an age where the daughter can understand and absorb the consequences of what this test is. And some kids are different. So I think that's where it becomes an individual decision.
If they were symptomatic, would you recommend it?
Yeah, go ahead.
Perfect. In carriers, is the cardiac fibrosis distributed throughout the heart, or is it usually concentrated in one area?
It's almost exactly like the boys. In the LV free wall, in the heart muscle itself. And that's a different pattern than somebody who's had a heart attack, for example. So you can distinguish those completely, but it's almost exactly the same.
So with what you just said, there's a different acceptable range between the left and the right? Which one should someone be more focused on, would you say?
The left. We don't see as much fibrosis in the right ventricle that we can see on MRI. There is some data looking at autopsy specimens and so forth, that there is fibrosis in the right ventricle, but it doesn't rise to the level that you can pick up on imaging.
Perfect. Does the type of mutation impact the percentage of risk of developing cardiomyopathy in carriers, to your knowledge?
If the person and I knew the answer to that question, we would be winning the Nobel Prize.
Wouldn't that be great?
It would be awesome. Up until now, specific mutation has not predicted cardiomyopathy risk. There was one paper that incorporated cardiac MRI and some components trying to predict what the dystrophin protein would look like based on the genetic variant. And they found a couple of variants maybe had milder cardiac involvement, but it did not distinguish those at most at risk for severe. So that's one of the areas we're working on and I'm focused on is, are there other genetic modifiers of disease independent of Duchenne that predict? So kind of the two-hit hypothesis, you inherited dystrophin mutation, but then you also inherited something else from mom or dad. And it's the two changes in DNA that put you at more risk.
So speaking of that, and I think I know the answer, but can you find which X is active on your genetic report? I don't believe that's the case. You have to actually have an observation test.
You have to, you have to either take cells or muscle tissue. And most people would suggest it's not a clinically meaningful test because there are patients who have skewed inactivation, but yet they don't have symptoms. And so I think it's an important research question, but it's not one that's clinically available.
Let's see. What interventions are recommended for carriers whose muscles are affected? Based on conversations on social media, it seems some are misdiagnosed with fibromyalgia. If symptoms can be similar, is it reasonable that they could be managed similarly?
And it depends on the symptoms, but probably managed differently. I think more attentive to muscle. We don't even know the impact of corticosteroids. Is this a role for vamorolone? I don't know. So I think there are many unknowns. I know that pain management and discomfort is managed differently in our neuromuscular patients compared to joint and inflammatory conditions. So I do think having testing showing an elevated CK and going to, I'm not sure what happened there.
I am so happy. I'm so sorry. I'm so happy that happened to you because that's happened to me multiple times on webinars, and I keep holding my hand so it doesn't happen to me.
Yeah, I don't know what happened, but I think what you don't want to do is somebody to dismiss you as not having something, and that's probably the most frustrating part, or somebody giving you a diagnosis that's not correct and going down a treatment path that is probably not accurate. And so I think that's where having the information is really important.
Let's see, just a few more. I had an MRI with contrast and they found prior myocarditis. They haven't had it before. Wondering if they're mistaking it for fibrosis.
Yes. Well, no, I don't know. But
it's probably that diffuse. We can
probably
I can more
more than likely they haven't seen it before in a boy and they don't know that it exists in a carrier mom. So,
I think there's a lot of lack of knowledge in the space about females in general. So I
well,
especially
yeah.
those that haven't
So
seen a boy, right?
if you're a 40-year-old radiologist or cardiologist and you maybe not even read about Duchenne, you're going to read it by what you see, um, and not maybe have the full picture. So,
Thank you. Um, how do I convince my doctor that I need to have a cardio checkup? They do not have genetic testing, but they have had a son with DMD.
I would take Dr. Ma's paper, which was published in 2020. The reference is on there, which
I can send it.
yeah. Um, and I would take that and say, I've got a 50-50 chance of having fibrosis on my heart. I want to know if I'm flipping a coin.
Thank you. And then many are aware of the risks of cardiomyopathy, but many may not know that that fibrosis can interfere with electrical function of the heart. Can you just speak a little bit to that piece?
Yeah, sure. And I don't know, we don't have a good idea of the long-term implications of that. We know that boys with Duchenne don't have a high incidence of ventricular arrhythmia and sudden death, but it usually follows heart muscle function. But I think the importance is in the exercise treadmill portion that's when things were elicited. So I think it's always important to know that it exists, and that may help guide a different treatment path, for example, where, like a beta blocker, for example, might be your drug of choice as opposed to an ACE inhibitor, for example, or an ACE inhibitor and a beta blocker. So I think it does carry some risk, and I think we don't know. So we can be optimistic, but we should not ignore.
And then is there a specific diagnostic code that you use for females that are symptomatic to get tests approved by insurance?
You usually use genetic carrier of disease, and you put in whatever that disease is and what the symptoms are. So chest pain, palpitations, and cardiomyopathy. I would add that in there.
And then I will have this as the last question, since I know we are almost at time, but beyond fibrosis, can DMD cause supraventricular tachycardia?
So yes, ish. We know that there's from a recent study with Jett Vila at Cincinnati, they looked at some autopsies, and there is fibrosis in the atria or the top chambers of the heart. And so, yes, you can have fast heart rhythms from the top chamber. And certainly, if you have poor heart muscle function, you're more likely to have heart rhythm issues. So, being attentive to that is important. And that might modify your treatment approach of which medication you pick to try to combat whatever the presenting symptom is.
Awesome. Well, thank you. Thank you. Thank you. I think this was super beneficial. I mean, the questions were wonderful. Thank you again for being here, sharing your knowledge and understanding
Sure.
that this is a population that's important because it's important to us as well. So thank you being the doctor that you are.
Yeah,
And if anybody does have any other questions, please reach out to me, alexa@jettfoundation.org, and I will send them to Dr. Markham to see if we can get you some answers. So thank you everybody for being here.
sure.
Again, this is recorded, so if you need anything, you can watch it later. We appreciate you all.
Yeah.
Have a wonderful day.
And if you want, you can just compile them all, and I'll just put my responses, and you can maybe send the whole thing out so that everybody sees other people's
Absolutely.
questions.
We will send out a survey, so if you do have any questions, you can put them into that survey and I will get them to him and we'll get you an answer as soon as we can. So again, thank you, everybody. We appreciate you. Have a good day.
Thank you very much.